I call it the clutter in the corner. I have 4 kids and we get a lot of clutters in the corner that we just stop seeing over time, right? It's just like it's
Right.
been there, it's there. I don't know why it's there. It's just it's just what's there until someone comes in with a new perspective and says, "Hey, what's that? What that doesn't belong there. Why is that there?" Right? Same thing
Hmm.
within our healthcare system. Someone's got to come along and say, "Why do you do it that way?" And it's just the way we've always done it is not an acceptable answer.
Welcome to Safe Space Made Simple, a practical podcast that guides clinical leaders and healthcare managers to create trust and support with their teams. I'm your host, Trace Hobson. Join me for weekly interviews, practical tools, and inspiring transformational stories of bringing people together in healthcare. Now, let's dive in. Hey, everybody, welcome to another episode of Safe Space Made Simple, the podcast that was created for clinical managers, leaders, and executives who are interested in generating a safe space for themselves and for their teams. I'm incredibly excited to have a very special guest on from the United States today, Kali Dayton, who is a nurse practitioner and also an ICU consultant who is doing incredibly innovative work in the world of healthcare. Now, Kali and I have a vibrant conversation about her work, how she got into it, and some of the things that she notices about generating a safe space with executive teams and ICU teams. I know that this episode is going to serve you and support you in your generating a safe space where you work. So without further ado, let's get right into the show. So, Kali, I'm so excited to have you here. Thank you for being on the show. And to begin with, I would just love it if you could introduce yourself to the audience and share with the people that are listening what it is that you do.
I'm Kali Dayton. I'm a nurse practitioner. My specialty is ICU, critical care medicine, and I am now a consultant. I train teams, ICU teams, to become awake and walking ICUs through mastering the ABCDEF bundle.
So, what is an awake and walk? When I first heard this term on LinkedIn, when I saw your work, I was like, "What is an awake and walking ICU?" So, from a layperson's perspective,
Yeah.
just for my benefit, because everybody who's listening is going to understand clinical practice much better than I do, but I would just love to hear, what is that?
It's an ICU that only gives sedation when there is an indication for sedation. So many ICUs automatically sedate everyone that's intubated. If they're on a ventilator, they're going to be in a coma, no matter the reason they're intubated, usually no matter their acuity, we just automatically sedate them. But an awake and walking ICU only gives sedation when there's a reason for it, such as seizures, intracranial hypertension. If a patient cannot oxygenate with movement, whether they have severe ARDS or cardiogenic shock, there are times when it's unavoidable. You have to sedate a patient, but an awake and walking ICU only does that when there is a reason to. And when there is a reason to, then they give the safest sedative at the lowest dose for the shortest duration possible. And patients are doing their highest level of mobility, meaning if they walked into the hospital, they're going to be walking in the ICU. If they were wheelchair bound, but they could wheel their own wheelchair, they're going to be doing at least sitting up at the side of the bed. We're going to be doing whatever they can do unless there's a contraindication for it. And there's open family visitation. Families are part of the ICU team. They don't get kicked out at night.
Wow. So, why are you so adamant about not sedating patients unless they absolutely have to have sedation? Where does this come from as a practice area or as something that you're advocating for?
Um, I advocate for this because sedation comes with high risks. We have come to really accept it as normal, and primarily because in the OR, when patients are having surgery, we give propofol, fentanyl, these medications for a few hours. It causes amnesia. They don't feel pain. We don't experience things when surgery. It is so important and does a great job in that kind of setting. But when those medications are given for days to weeks, they have an entirely different effect and come with a lot of risks. For example, sedation disrupts the brain. So we cannot get REM cycle 3 and 4. So it causes
Hmm.
sleep deprivation. Sleep deprivation alone is lethal. If If you torture someone and you deprive them of sleep for 4 days, they come out with a brain injury. They develop delirium. They have hallucinations. They have a lot of trauma. They have physical impairments that they can live with the rest of their lives. Patients come to us in the ICU very vulnerable. Their brains are under attack from a lot of systemic inflammation. A lot of things are happening to the brain. So we need to be really careful about what we contribute to any kind of disruption to the brain. And sedation is very toxic to the brain, especially medications like benzodiazepines, but even propofol, opioids. They have a place. They can be used, but we need to really do a risk versus benefit analysis. And so rewinding to the history of critical care medicine, we didn't put patients into medically induced comas. Back in the 80s, if they had a breathing tube, they were usually awake and usually mobile. But these were not the kind of patients that we take care of in our ICUs today. These were not nearly as sick. If they got sicker, they usually just died. But in the 1990s, we started to experiment with diagnoses like acute respiratory distress syndrome, like ARDS. And we were giving huge lung volumes. The volume of oxygen and air that we were giving were 2 and 3 times what we give now, 12 milliliters per kilogram. And so that was just making these lungs basically explode. And they were getting pneumothoraces at high rates. And they had stiff endotracheal tubes. These ventilators were very simple. They just pounded air in and pulled it out. So understanding that, it makes sense that these patients could not synchronize the ventilator. They couldn't tolerate being awake. It was torture, and it really wasn't working. So the theory was that we had to give all this pressure to make these stiff lungs inflate. So then we started bringing up medications from the OR, these barbiturates, benzodiazepines, paralytics, and we were giving them not for a few hours, but now for a few days to weeks. And we didn't have research back then to tell us what the cost of that would be, how that would impact and their lives. Later on, in the late 1990s, we looked back at those patients and we found that it was very lethal to give that much long volume by the ventilator. And so we stopped doing that. We also later looked at the very few survivors of ARDS during that time and found that those that did survive had severe physical, cognitive, and psychological impairments. So their lungs got better from the ARDS, but now they had brain injuries. They had memory loss. They were dysfunctional. They couldn't go back to work. They couldn't take care of themselves. They were very fatigued. Their lives were entirely different, but their lungs were better. And so it created this question of, why is that happening? They found a strong correlation between those impairments that we now call post-ICU syndrome and how much and how long patients received sedation. So this approach is important because what we do in the ICU can determine whether or not patients survive and what kind of lives they go back to. So in the ICU, when we started this process with ARDS of automatically sedating these patients, it spread like wildfire throughout the ICU community, not just for patients with ARDS, but for patients that were being intubated for any reason, because we saw that they synchronized with the ventilator better, their oxygenation improved, and best yet, their eyes were closed and they were still. And we believed that they were sleeping. And we didn't have the evidence or the research yet to prove otherwise. So this belief that it was more humane, safer, easier, better for patients to have them comatose laying there lifeless spread like wildfire. Like I said, it went throughout the entire community. And so now here we are in 2024, and we're still combating that, even though we have decades of research showing that, for example, when patients are sedated deep enough to not respond to voice, that alone is an independent predictor of death. It's also an independent predictor of delirium, which is acute brain failure. So we're causing an organ failure. Someone can come in with simple pneumonia and they can leave with a new brain injury. And the outcomes of this brain injury, the cognitive function levels are similar to mild Alzheimer's and moderate traumatic brain injury. And that can be induced by sedation. Delirium that sedation can cause doubles the risk of dying in the hospital. And so we can give them a brain injury. We can also cause a new neuromuscular condition. You can lose 40% of your muscle mass within 10 days in the ICU.
Whoa.
So I didn't know that starting my career. Most ICU clinicians do not understand that information because this has been a culture an environment that we inherited from previous generations, very few people question this. It's just par for the course.
Mm-hmm.
You come to the ICU, you have a hard time. You need a ventilator for a multitude of reasons.
Mm-hmm.
The classic cocktail is intubate, sedate. You're going to lose your muscle mass. You're going to have a lot of confusion, delirium, and you're likely to have a trach, go to a care facility to rehabilitate. High risk of coming back to the ICU from complications from that, high risk of death. And because this is so normal, we don't really question it. And so my experience is really different because, well, I'll start the very first time I ever entered an ICU was in 2009. I was a nursing student. And I was so excited. My dream was to work in the ICU. So here I come in for my first night shift, and I'm so excited. And I'm sure I was way too chatty. And the night nurse said, hold on. If you think that this is going to be social hour, you are sadly mistaken. I work in the ICU and on nights so that I don't have to talk to anybody. And I was heartbroken. But I realized that kind of was the culture. Not every nurse is like that, right? She was an outlier. She was especially abrasive, but there is a culture of we want them to be voiceless, still. We just want to do all the drips and all the tubes and all the drains and stuff. And that's the culture because that's all we've ever known. And we feel comfortable with that. Now, I kind of forgot about that experience. And for some reason, I still wanted to work in the ICU. So in 2012, I was finally getting my first interview into an ICU. And the nurse manager, Nancy Bartigan, she basically said, "Hi, how are you?" And her next question almost immediately was, "Would you be willing to walk patients on ventilators?" And I was so green, so new. I didn't even know what that really meant. So I said, "Yes, totally. Absolutely. But you'll have to teach me everything." And I think back to that interview with Nancy, and that was really a pivotal moment in my career. The fact that she made it so clear that that is what they do in their ICU, that they were going to keep patients awake and mobile. And if I was not interested in doing that, I was not going to fit in on that team. I realized that Nancy really controlled the culture. She also said, we're a learning environment. You're going to make mistakes. We make mistakes and we learn from them together. She created a sense of safety. So even though I didn't know exactly how to do this thing that she was expecting me to do, she assured me that the team was going to help me be able to take care of patients in that way.
Right.
So spending 2 years in that environment, I was brainwashed. Almost all my patients were awake. Many of them were walking around the halls. I barely knew how to titrate sedation. Didn't know much about it because most of my patients were awake. They could write on a clipboard, text. They could really communicate. I knew what they needed. I knew who they were. I loved it. But I was 24 at the time, looking for adventure, left to be a travel nurse, and suddenly went to a normal ICU, got my patient assignment, and immediately noticed my patient was sedated. And my routine in my shift was to do a neuro exam, get my patient to the chair, get them ready and waiting for physical therapy to come. And none of that was possible. And I didn't know why my patient was sedated. And I was asking questions like, why are they sedated? And the nurse that was orienting me looked at me like I was speaking French and said, because they're intubated, which made no sense to me because that was the first time that it ever been proposed to me that a
So
patient
you
would
literally
automatically.
didn't know that there was a difference because that's the way you learned from the beginning.
No, the only prep I got was a very cryptic message from the founder of that process, Polly Bailey. She was a nurse practitioner there. And she said, it's going to be different when you go elsewhere. And I didn't know what that
Interesting.
meant. And I was like, yeah, I'm looking for
Right.
different, bigger experiences. No one told me what was waiting for me.
Wow.
And so they probably questioned whether or not I'd ever worked in an ICU. I'm sure they thought I wasn't safe to practice because they didn't know what I was talking about. When I'd say, oh, I'm just used to my patients being awake and taking them on walks and stuff. And they would say, well, do you follow them with an intubation cart? And they just thought I was an idiot. I didn't know what I was talking about. They didn't think it was possible. So I just ended up, culture is so powerful, right?
Mm-hmm.
And the ICU, there's this, it's almost like initiation. If you're going to be an ICU nurse, you got to go with the protocol, which is intubate, sedate. Those are the patients you want. I didn't fit in, but I wanted to fit in. So I just thought, okay, when in Rome, I'm just going to do what everyone else does because I didn't understand the why. I wasn't educated on what sedation actually does. I didn't understand the benefits of where it had come from. So I just shut up and did what everyone else was doing for 2 years. I
Wow.
worked in many other ICUs and it was always the same. And I would always think about where I came from. And I'm like, wow, I miss that. I miss the human contact. I miss the environment. I miss the culture. I miss my team. I especially miss watching patients walk out the doors and go home because I was seeing a
Hmm.
lot of bad outcomes that I later learned had a lot to do with those sedation mobility practices. So when I returned to my home ICU during grad school, I had a lot of questions because I almost had another level of shock. I realized how sick these patients were, multi-organ failure, septic shock, ARDS, but we had them walking through the halls. And I sat my mentors down, these nurse practitioners, Louise Bestian and Polly Bailey, and I said, okay, break it down for me. Why are you the only team to be doing this?
Hmm.
I also worked in a multi-hospital system and I was doing the float pool. So I was going around to like 11 different ICUs within that same city. And this was the only team where I got to treat patients that way.
Right.
And so I had this big dichotomy in my mind of, okay, I'm seeing these outcomes and see what we can do. And every time I learned about the harm of what I had been doing for 2 years, I kept thinking, my colleagues in all these other ICUs throughout the country don't know this. If they knew this, they would do it, but they have no idea. I didn't know I was harming patients. So it just weighed really heavily on me. And it led me to start the podcast, Walking Home from the ICU, which has evolved into consulting business, where I now
Hmm.
train teams to completely revolutionize how they care for patients.
Yeah, this is amazing, Kaylee. And as I think about why it is that so many ICUs are not doing a practice like you're describing, it makes me wonder back to what you were saying about how keeping the patients intubated, sedated, sort of just the drip. We don't have to worry about any voices in the room. Do you think that that has an indication at a higher level in organizations around just trying to control costs or just trying to, keep the sort of the it almost feels like it's a commoditized the whole process, taking humanity out of it. And I wonder why that is. I guess I'm reaching for, like, maybe it's about money, but I don't know if it is. Like, why
Well,
do you think that that culture is so pervasive if there's such a better approach like you learned originally?
well, let's talk about the money first, because what I always hear is we don't have enough staffing for it, and we can't get fiscal support to do this.
Hmm.
The terrible irony is that this approach decreases healthcare costs in the ICU by at least 30%.
How
So that
so?
that decreases length of stay by days to weeks,
Okay.
decreases time on the ventilator by this approach of no sedation decreases time on the ventilator on average by 4.2 days, time in the ICU by 2 to 9 days. So decreases readmissions by at least 46%. Patients are
Whoa.
36% more likely to go home rather than to a care facility.
Hmm.
Talked about delirium, this acute brain failure.
Right.
That alone increases costs by 39%. ICU
Wow.
acquired weakness, so losing most of your muscle mass and function, that increases costs alone by 30.5%.
Hmm.
So it's incredible to try to put together how much failing to practice this way ends up costing our hospitals and our healthcare systems. It also is a huge psychological burden when you are working
Right.
so hard to turn a patient every 2 hours, run the sedation, run the vasopressors to compensate for the hypotension that sedation causes. You're putting in central lines to run those vasopressors for the sedation. Um, you are taking care of ventilators for weeks on end with these patients that are, excuse my French, but they're basically decomposing zombies in the bed. You don't get the satisfaction of human connection. You don't get to have the reward of them successfully extubating, talking to you, telling you thank you,
Hmm.
walking out the doors, watching them love and kiss and hug their loved ones while they're standing up at the side of the bed while intubated. You get deprived of that whole experience.
Hmm.
So clinicians are used to this, and I don't think they really understand the toll that it takes on their souls, and how hard it is on the team to sustain this process of care because it's so normal. I call it the clutter in the corner. I have 4 kids and we get a lot of clutters in the corner that we just stop seeing over time, right? It's just like it's
Right.
been there, it's there. I don't know why it's there. It's just what's there until someone comes in with a new perspective and says, "Hey, what's that? What that doesn't belong there. Why is that there?" Right? Same thing
Hmm.
within our healthcare system. Someone's got to come along and say, "Why do you do it that way?" And it's just the way we've always done it is not an acceptable answer.
Right.
So people think it's about the money. And I do think that in many ICUs, when you are staffing your ratios three patients to one nurse, this process is not feasible. My home ICU, we had 2 patients to each nurse,
Mm-hmm.
and it was fine. But we also had a team dynamic in which everyone was contributing. I was getting separate PT and OT therapists coming in, visiting my patients, working with them, communicating with them, helping them work through their anxiety, wearing them out so they would take a nap in between. They developed less delirium, so then they were over 11 times less likely to pull out their tube. Right now in our facilities, we don't really consult physical and occupational therapists until way later in an ICU stay. Now
Right.
they're so weak and debilitated that it takes a physical and occupational therapist together to
Mm-hmm.
set up this floppy, flaccid body that can't follow commands. And now you get like 10 minutes rather than full 30 minutes with each discipline. There's just so much that goes into making this feasible that our teams are not structured to do. They could be.
Mm-hmm.
There's just not, because they haven't had that focus. This ABCDF bundle, it's a toolkit. It's a toolbox full of tools to achieve the goal of being in awake and walking ICU. But when that was rolled out in the 2010s, because it was such a huge contrast, it was pretty much interpreted as lighten sedation, turn it off every morning, check to see if they can be off the ventilator. If they can't be, turn the sedation back on, try again tomorrow. And at the end, if you get them off the ventilator, you can mobilize them. So people will say, well, we practice the bundle. And my role is to say, but what does the bundle mean to you? Is it just an on and off switch for sedation, or is it to create an awake and walking ICUs where patients are awake, autonomous, communicative, and mobile? Because if that is your goal, but yet you're just doing a checklist with a bundle, you're not totally compliant. And therefore, they don't get the benefits of it financially. They don't get
Mm-hmm.
to have the release of ease of burnout, turnover, things like that.
Mm-hmm.
And they don't really know how to work together as a team. So everything just stays heavy and stuck in the ICU.
Right. Hey, just a quick pause to today's podcast. Are you having a challenge as a clinical leader with one or more individuals who you find activate you on your team? Or maybe you're noticing that oftentimes you want to be able to communicate with people, but in the heat of the moment, it's difficult for you because you're having a difficult time regulating yourself. Well, I totally understand this. This has been some of the biggest challenges in my life as a leader and as a human being. And so I created a free resource for clinical leaders, nurse educators, and healthcare executives called the Relationship Regulator. It's a mini course that will show you step by step a framework that may serve you very powerfully in this area. So if you want to download the Relationship Regulator for free, click in the show notes and you'll find that resource for you today. Now, back to the show. You mentioned earlier that in your initial training in the ICU, that the clinical manager there created safety, and I would say that was psychological health and safety,
Yes.
and a sense of being able to be a learner in that environment and to try different things that maybe are out of your comfort zone. I'm curious about how psychological health and safety or creating a safe space applies to your work now, and how you're actually doing that with different teams that you're working with.
Yeah, this has been fascinating to me, because I came from an environment in which if something happened, we would just talk about it. I mean, you would report it, but you didn't
Right.
get called into the nurse manager's office and get reamed about it. Because I was so green and I was enthusiastic about life, they took that and they let me continue to be that.
Hmm.
For example, I'm a singer and I wasn't trained to sing to my patients, but it was an environment in which it was encouraged. It was okay. No one really judged me about it. It seemed like an appropriate thing to do because that's what we focus on, was humanizing the ICU. Now, if I were to go do that in another ICU right now, I might get a lot of weird looks. So it was a place where I could continue to be myself, be the kind of nurse I wanted to be, fulfill my desires and mission for my career. And I had a whole team supporting me in that. And a lot of that was because it was a safe place. Now, what I see in many ICUs now is throughout the years, we've in with good intentions, we've created a lot of fear. For example, we are terrified of falls. So instead of preventing falls, we've taken that fear and turned it into strap everyone down to the bed, sedate them if they're moving, don't let them get out of bed, don't let them sit in the chair because they could fall. And if they fall, it's going to be your license. You're going to be written up. You're going to be in trouble. It's all on you, nurse. Also, this also happens with unplanned extubations. So if someone pulls out their breathing tube, you're a failure. It's your fault. That's a worst case scenario. You killed your patient, even though in some studies, it shows that patients that get their breathing tube out by themselves survive better than those that didn't. So that fear a lot of times is not based in evidence. It's cultural. So the psychological safety as far as, is my leadership going to punish me? Is this a punitive environment from up down, or is it lateral punishment? So am I going to be judged by my colleagues if my patient gets their tube out? For example, one of my colleagues, he'd been a CNA in my home ICU. So he was brainwashed too. That's all he ever knew. Then he became a nurse. He practiced for a nurse as a nurse there for a few years and then went to a different ICU. Had the same kind of shock. And he would work so hard all shift to get his patients awake, writing on a clipboard, even sitting in a chair. I mean, he was doing this all by himself, and the environment did not support that. So when he'd have a patient unrestrained and suctioning their own mouths out, his colleagues would pass by and almost tackle the patient to the ground, thinking that just because their hand is by their mouth, that they're going to pull the tube out. So then he had to almost convince his colleagues to let him do that because they thought that was, quote, unsafe. So it wasn't psychologically safe for him. He knew that if he was going to do this for this patient, even though it was the right thing to do, he was going to have to fight his colleagues on it. If he went to break, he knew that if he came back, his patient was probably going to be sedated by whatever nurse was watching that patient. And then he would leave for that shift, and the night nurse would come on and resedate his patient. And he'd spend all day the next day trying to get them cleared out of the sedation, oriented again, comfortable again. And so psychologically, it was torturous. So we instill this punitive environment. We're worried about the wrong thing. And the ironic thing about falls and unplanned extubations, for example, is that 75% of falls happen in the setting of delirium. Midazolam is now one of our favorite drugs in the community. Unfortunately, it's a benzodiazepine. It doubles the risk of falls. Unplanned extubations, delirium increases the risk of those by over 11 times.
Whoa.
And yet we're taught culturally to sedate patients to keep them safe and to keep the tube in. So we have a lot of fear-based culture, decision-making, and a punitive environment where if this happens, they're going to get in trouble. And what I love hearing is when this starts to change. So for example, some podcast listeners told me a few stories. One said that she had a patient on higher ventilator settings who's pretty sick. Her team did not want patients to be awake, but this guy was doing fine. He was doing great. And she wanted to keep him awake. He even wrote on his clipboard, I won't pull the tube out. But he had some psych stuff and she wasn't super sure if she could trust him. And she asked for a sitter, someone to come and watch him so she could check on her other patient. And her nurse management said, no, just sedate him. He shouldn't even be awake. Sedate him. Sedate him. And she just ethically felt like she couldn't do that. So she said, okay, bud, I'm going to trust you on this. Don't pull it out. Well, she goes to check on her patient and he pulls it out. And so she gets pulled into her nurse manager's office and they're just ready to rip her a new one because they said, you should have sedated him. And this is the worst thing that could have happened. He was fine. They reintubated him. The patient was fine. And so the attending physician comes in and says, hold on. If she gets any heat for this, you'll have me to report to you because she's practicing better evidence-based medicine than the rest of us. So she needed an ally. Otherwise, it would have been a punitive environment for keeping this patient awake and mobile, when really the evidence says that that's what we should be doing.
Wow.
So nurse leadership should have been, okay, how can we support you in achieving this goal and doing the right thing for the patient?
So as you're going into different teams now and you're consulting ICU leadership teams as well as the clinicians on the floor, what kinds of things are you teaching them and what kind of education are you giving them to help them overcome that initial sort of, resistance that they have because they've learned an old way of practicing?
this has been a journey throughout the last few years because in my mind, because my home ICU was such a well-oiled machine, they've done this for almost 30 years.
Wow.
So I don't think I really appreciated all that goes into it, right? Systematically.
Mm-hmm.
So initially, when I started my podcast back in 2020, I was just like, hey, just don't turn sedation off and on and get them up. It's that easy. And eventually it does become that easy. But to get there, I had to really learn about where these beliefs came from, the perspective of the clinicians, the fear, the psychological safety of the units. I also came to appreciate that in this initial rollout of this bundle back in the 2010s, some good things were implemented, some requirements in the computer charting system that should prompt clinicians to assess certain things and do certain things. So there was a lot of how that was implemented, but they missed the why. Most clinicians did not learn about what it's like to be sedated. So most believe that they're sleeping, that they're spared trauma, that they're unaware of their environment. They don't feel pain. The less they move, the better off they are. Because when they turn sedation off, these patients come out thrashing, coughing, gagging. It's really stressful. But when you turn sedation back on, it all stops. So there's a lot of misinformation and myths that influence how they care for patients. But until we address that, we'll never get them to figure out the how.
Mm-hmm.
They believe that not just that sedation is sleep, they believe because of that experience, they believe that any patient that's off sedation is going to be trying to self-extubate. They believe that they're going to fall. They believe that it's going to be twice the work. There are lots of things that they're so afraid of. So until they really understand the science behind it, the why we need to change what we're doing, they'll never be open to doing something different. So when I train teams, I start off with a webinar program where I start systematically on addressing those fears, the misinformation, so that they understand the problem that we're going to try to address. Then I'm meeting with each champion or each director of each department and being really clear about their role. This is not just on nurses. RT, here's your job. PT and OT, here's your job. Physicians, here's what we need from you. And making sure that they're really bought in and they have some skin in the game. Then I show up with a physical or occupational therapist, a respiratory therapist, and myself. We show up as a team because we need to represent that this is a whole team needing to be engaged with this.
Right.
And then we do simulation training where each discipline, every member of the ICU team is going to participate in these simulation trainings and together. So they're standing, a CNA is standing shoulder to shoulder with a physician who's next to an RT, next to a PT and OT. So we figure out what do we all need to be doing to make this happen? And we go through case studies and we practice critically thinking and collaborating on their own patients. So I take case examples from their own unit so they can see through, okay, what we did here caused this harm and this outcome. Here's what we need to do. Here's what we're going to do. And I can ask physical therapists, what do you need from nurses? Nurses, what do you need from physicians? Physicians, what do you need from respiratory therapists? And so we can actually talk about what we're going to do as a team. No one else is doing this. Teams have never been exposed to this. So 2019, I was interviewing in a different hospital in the hometown where I grew up because I wanted to move my family there. But I also knew at that point that I couldn't be a chameleon. I couldn't just follow the protocols. As a nurse practitioner, I wasn't just going to write those sedation orders. So I had to be true to my values when I interviewed in this new ICU. And I said, the greatest value I can bring is to help you get your patients awake and walk in the ventilator. And then medical, yeah, good luck with that. There's research supports that, but you'll never get our nurses to do that. And that just, even still, I get all sweaty about it, right? Because you'll never get our nurses to do that. I had worked at that point like 13 different ICUs. I met the most amazing nurses, so skilled, so competent, so compassionate. Don't you dare tell me that they won't do that. Have you supported them? Have you trained them? Have you yourself as a physician and a medical director gone into the room and helped them get the patient up and taught them how to do it? If you haven't done that, don't tell me they won't do that. So I repeat that in my mind all the time when I approach these teams because they'll say, oh man, so-and-so is going to be really difficult. And this group, whether it's RTs, PTs, RNs, everyone has different barriers. And people will always say, oh, I don't know if we'll get them on board. And I just say, hold on. Let them understand the why. Here's how you're going to support them. And it's amazing to see the biggest naysayers, the people that sometimes are the most toxic, talk the most, can I say crap on the podcast?
Yeah, of
They talk
course
the
you
most crap, right? People will say to me, before you came here, we had all sorts of things to say about you and to you. They'd say things like, who died and made Kaylee queen? But those people, almost without fail, become some of the biggest advocates and the captains of the ship.
Right.
Because they actually got to see the why.
Mm-hmm.
They were supported in learning the how, and they got to see what this actually means. Once they see how beneficial it is for patients, how safe it actually is, they're no longer so afraid.
Right.
They know that their leadership has their back. They know their team is going to help them get it done. And then they own it and they run with it. And that's when you know you've got a culture that's going to thrive.
Wow. So, Kaylee, you're obviously full of a lot of fire for this particular topic. And I loved listening to your podcast as well. And I'm just thinking, as people are listening, what are some things that they could do, or what are some of the offerings that you have that could support them in getting some of this education for their ICU? And how can people get in touch with you? What's the best way to get in touch with you?
So my website is DaytonICUconsulting.com. You can email me from there. You can make an appointment with me from there. One of the first things I invite people to do is to do an audit. Because usually people are reaching out saying, I believe in this, but I feel very alone. And I call podcast listeners and people that I want to bring these changes, I call them ICU revolutionists. And it can be really lonely and really challenging to be the only revolutionist in your team. So one of the things that needs to happen is we need to have objective data. Because like I said, people will say, oh, we practice the bundle. So sometimes it'll be a physical therapist or a nurse that say, I can't get my team on board. And my director says that we already do this. I send them an audit tool where they can go and they can not just look at what's charted, because the charting is not reliable right now. We can make up all sorts of things in the charting and it looks compliant, which is a whole nother discussion. So I have people do an audit. How deeply are patients sedated? Not just what's charted, but what's actually happening at the bedside. What is their RAS goal? Are we screening for delirium? Not just what's charted, but what do you observe? So I have them find someone that's very objective, usually not a nurse, a physical therapist, or a pharmacist. Someone goes in and does this audit throughout the unit for like 2 weeks. Now we can see how compliant are we? And there's some things that really stand out in those audits. For example, if nurses are charting a certain sedative level, but it's different at the bedside, or that means that they're usually giving more sedation than is what's ordered. That gives us more objective data to show to the medical director to say, hey, we've got a problem. This is a legal liability. This increases cost. This increases mortality.
Mm-hmm.
And finally, they're willing to listen. Another important thing to do with that data is to present it to the executive leadership team. They need to understand the costs of these normal practices. They make decisions without understanding the evidence behind this. For example, I presented about a year ago to a hospital that had 5 ICUs, and they had just downsized their physical therapy department. And so here I am explaining that was very expensive, and just watching their eyes get bigger and their jaws drop helped them realize that was not a wise financial decision. They thought they were cutting costs, but they're actually increasing costs by doing that. Right. So through presenting to them in person about their data, I was able to win them mobility techs, as well as the opportunity to train their ICUs. So I've learned throughout much trial and error that I need to just get directly to the executive leadership team and talk money. And then finally, the teams have support. Then finally, your CMO is talking to your medical director saying, hey, how's it going in there? Are you getting this done? Where's my return on investment? I want my money. Now we have some feet to the fire and things actually start happening. So nice. I'm available to do that. I'll even fly out in person and meet with your teams, your executive leadership teams, and talk to them about where they're at, where they're losing money, and how they can save money through supporting your team.
That's amazing, Kaylee. Thank you so much for coming on the show. And for those that are listening, definitely we'll have the links to Kaylee's podcast and her website in the show notes. And so you can find that there. And again, Kaylee, thank you so much for being here.
I appreciate it.
Thank you so much for listening to the podcast and for hearing this particular story that amplifies incredible work that's being done in healthcare to be innovative and to do something different. Now, if you'd like to get a hold of Kali, look in the show notes and reach out to her. And I know that she would really appreciate it if you could share with her what this episode was like for you, how it impacted you, and just share a couple of good words with her on LinkedIn or by email. I also know that if you're interested in getting some more information, if you're leading an ICU or you're working within an ICU and you'd like to meet with Kali about her work, I know that she'd be more than happy to do that. Thank you so much again for listening to the show and for supporting the work that we're doing. I appreciate you. And remember to be a safe space. Thank you again for getting to the end of this podcast. And if you enjoyed this and you found that there was value in it for you, my invitation is for you to subscribe for future episodes that come out weekly on Tuesdays. Thank you again, and I'm looking forward to being with you next time. Now remember to be a safe space.